Welcome to Cardio Risk 20. معنا دلوقتي دكتور أحمد البنداري. أهلا بحضرتك يا دكتور.
Thank you. Thank you, sir.
أهلا بحضرتك.
Thank you, sir.
Could you please introduce yourself?
Hello, everyone. Good morning if you are hearing us at morning, or good evening if you are at night. This is Ahmed Bendary, lecturer of cardiovascular medicine in the cardiology department at Bendary University, and this is Cardio Risk TV.
Welcome يا دكتور. We're honored to have you in Cardio Risk.
Thank you.
كنت عايزة أسأل حضرتك إيه رأي حضرتك في المؤتمر السنة دي؟
الحقيقة it's an outstanding meeting. من أول ما دكتور أشرف رضا founded the Lipid Day more than 10 years ago, and this meeting زي ما بنقول is gathering the largest cardiology ever you could meet in your life. Many lectures, many key opinion leaders, interesting sessions. We are just leaving the Cardio Risk Rising Stars, in which the knowledge is presented by competition in the form of MCQ questions. The industry symposiums are also full of knowledge and full of excitement. Really, I love this meeting, and I love the idea that's hybrid this year amid the COVID-19 pandemic. We hope you keep all safe.
Thank you يا دكتور. We're really honored to have you. طيب كنت عايزة أسأل حضرتك إيه الجديد in the area of transcatheter aortic valve replacement in high-risk patients?
Yes, one of the highest risk is those patients with concomitant severe aortic stenosis and active cancer. Those patients, unfortunately, are not offered the surgical aortic valve replacement due to concerns over the higher post-operative complications and the need to withhold cancer therapeutics perioperatively. Moreover, those patients have been largely excluded from the pivotal TAVR trials, leaving a very little piece of evidence to guide the clinical decision-making. In a meta-analysis, which was published recently by our group in PMJ Open Heart and was covered in a specific featured in news article in Medscape Cardiology and TCT MD, we searched the PubMed, the Scopus, the Cochrane Library from any time before down to April 2019 for studies comparing the outcome of TAVR in those patients with active cancer compared to those patients without. We estimated the bold estimate of the relative risk of all-cause mortality at 30 days and 1 year. We also evaluated a 4-point safety outcome: any bleeding, any stroke, the acute kidney injury, and the need to implant a pacemaker. We also evaluated a 2-point efficacy outcome. They were the device success and also the mean difference in the transcatheter gradient. 3 studies were included, comprising more than 5,000 patients. Among those patients, 7.1 had active cancer. The commonest types of cancers in decreasing order of frequencies were gastrointestinal, prostate, and then the female breast.
So what are the results of the meta-analysis?
Overall, we found no difference, and I'll say it again, no difference in the 30-day all-cause mortality between those patients with cancer and those patients without. However, when it comes to evaluating the 1-year all-cause mortality, those patients with cancer showed a significantly higher 1-year all-cause mortality. But sit down for this difference was dependent on the cancer stage. In other words, those patients with limited cancer showed similar, both 30-day and 1-year all-cause mortality compared to those patients without. But those patients with advanced stages of cancer showed, and this is a surprise, still similar 30-day all-cause mortality, but of course the 1-year all-cause mortality in them were higher, and this was mainly non-cardiovascular. Importantly, there was no significant difference between both groups in the incidence of acute kidney injury, strokes, or bleeding. The only only safety signal that appeared in patients with active cancer is a significantly higher need to implant a pacemaker. And this needs an explanation. You know, the cancer therapeutics such as 5-hydroxyuracil, cisplatin, has an impact on the conductive tissue of the heart. And this could make the conductive tissue of the heart more vulnerable to any future mechanical injury imposed by the TAVR procedure. Actually, current guidelines do not support the treatment of those patients by TAVR whose life expectancy is less than 1 year. And so our findings is that the 1-year all-cause mortality is dependent on the cancer stage is noteworthy, but needs to be interpreted with caution, taking into account the observational nature of the studies and the heterogeneity of the included population. Moreover, determining the future mortality in cancer patients is difficult, and cancer itself is not represented into the conventional preoperative risk score such as the STS score. So, including an oncologist into the clinical decision-making is of paramount importance, because oncologists usually take into account the cancer stage into their decision, and this could help refine the risk assessment tool and help exclusion of those patients in which TAVR procedure could be futile.
So what's exactly the significance of this paper?
Yeah, the significance of this paper, or let me say the merit of this paper, comes in 2 points. The first point is that this is the first meta-analysis in the literature ever done about this issue. The second point is that it comes from many countries with many operators and many devices, and this could imply that any finding from this meta-analysis is extrapolatable to a wide range of patients. Finally, I'd like to say a final word. Cardio-oncology is applicable to anyone, me or you, anytime. Thus, incorporating an oncologist with cardiologists is indispensable. And the findings of this meta-analysis could or should set the stage for TAVR as an acceptable, attractive treatment option for those patients. It's sad to see a cancer patient dying of valvular problem rather than cancer itself.
Yes,
Thank you.
Of course. Thank you so much. We have the pleasure to have you today. Thank you so much.
It's my pleasure. Goodbye.